I thank you very much, Milton and Zeph, for giving me the opportunity to be here today and talk to you. And as you have already found out, I'm not a genetician. I'm a clinician, and I'm doing this lecture on behalf of my genetician, who was supposed actually to come and give the lecture, but he's very seriously ill, and we are counting the months and weeks that he's still with us. So the topic I was asked to present to you is polar body genetic screening and using of new techniques like RACGH and NGS. And the basic problems that we are facing in ART are advanced maternal age, repeated implantation failure, and repeated pregnancy loss. And you all are acquainted with these graphs, seeing the reduction in the number of the follicles with advanced maternal age and decreasing the quality of the oocyte with advanced maternal age. Now, the main reason why the quality is reduced is the aneuploidy of the oocyte, which is increasing with advanced maternal age. And because of that, preimplantation genetic testing was catching up in the last years. And as you have already heard before, there are different ways how to test these embryos. You can go for the polar bodies. You can test on day 3. You can do trophectoderm biopsy, and nowadays even use the fluid from the blastocyst to check for genetic testing. Now, aneuploidies originate mainly as a defective segregation error during the female meiosis and are the single most important factor contributing to oocyte and embryo quality. One of the main reasons is the spindle. On the upper side, here you can see a spindle from a young patient, and in the bottom you will see a spindle from an older patient. So you can imagine that this spindles of the older patient is non-functioning properly. Another problem is the loss of cohesion and the loss of attachment between the chromatids and the chromosomes, which is also one of the most important reasons why we have errors in the meiosis. In the first meiosis, we can have two different ways of errors. The one is called the non-disjunction, and the other one is called the predivision. And it is very crucial to understand how meiosis work in order to make the correct interpretation of the genetic information that you are getting when you do the testing. So here you will see on this side here, this is a normal meiosis. So you have two chromosomes, and then one chromosome will be discarded into the polar body after the first meiosis. And then in the second meiosis, you have one chromatid going, and one chromatid is left in the nucleus of the oocyte. But when you have non-disjunctions, you can have two different situations. Either you lose both chromosomes into the polar body, or you keep both chromosomes in the nucleus, and then there are two possibilities after that to correct the situation. Either you lose both chromosomes into the next polar body, or you are left with two chromatids. But this way of non-disjunctions in the first meiosis occurs only in about 3% of the cases. The other situation is the premature separation, or so-called predivision, of the sister chromatids. And here what you are happening is that you are getting different amounts of chromatids in the first polar body and different amount of chromatids left. So you are getting at the end 4 different end results that you will need to be able to be interpreting them. And you can also have what's called reverse segregation, and here you can have 3 different end results of the chromatids in the polar bodies or in the nucleus of the oocytes. So, as I said before, it's very crucial to understand all this and to make the correct interpretation after that when you look at the results. And it has been shown that pre-division and the reverse segregation are the most common pattern that you will see in the meiosis. It has been shown that risk of chromosome segregation error is independent for each oocyte. So each oocyte is dependent for itself. And the euploidity rate per metaphase 2 oocyte is constant as the number of metaphase 2 oocyte collected increases. So the rate will be always the same. Now, as you heard in the previous talk, blastocyst biopsy or trophectoderm biopsy has been the main way to look in the last years into polar body, into the genetic testing of the preimplantation. And the reason was the advantages that you might have more DNA because you are collecting more cells. It was believed that there is less mosaicism using the trophectoderm compared to the day 3 embryos, which were very highly mosaic. And you have also less embryos to process, so it's maybe cheaper and more cost-effective for the patient. And as we heard also before, it can facilitate single embryo transfer to reduce the problem of multiples, and some people also believe that frozen cycles give a better environment for the transfer, so they believe that they will have a higher pregnancy rate because the endometrium will be better for the transfer. But there are pitfalls. Even though in the best groups we can see that the pregnancy rate and the implantation rate is not 100%, even if you transfer a euploid blastocyst. Also, the pregnancy loss was not 0% in those patients. And it has been shown that blastocysts must achieve a very good morphological quality in order to undergo the blastocyst biopsy, and otherwise they would have been discarded or not used. And then the big question of mosaicism and what you do with segmental aneuploidy. So this is a paper published just last year to show that in the number of biopsied trophectoderm cells was likely to affect the implantation potential of blastocysts with poor trophectoderm quality. So as you can see here, these are different quality of morphological quality of the blastocyst, and the more cell that has been taken, the less the probability of implantation of this blastocyst, even though it was euploid. And the question of mosaicism came up, and here just to try to explain, and I'm sure that Norbert Gleicher will do a little bit more about that in the next debate. As you can see, this will be a day 3 embryos, and if you have not normal aneuploid cells in there, you will not know where they go and what will happen to them in the trophectoderm, where they will be placed. They will become apoptotic or they will continue to develop, and there is no real information about the inner cell mass and how that will relate to the trophectoderm cells. And if you do now your biopsy, then you only do one biopsy on the trophectoderm. It depends now very much on which area you are taking your biopsy, and this will be the cells that you will be trying to make an interpretation about the inner cell mass, and that will not always be correct. So if you look in the literature, the mosaic rate goes very high, from 5 to 10% in some centers, up to more than 50% reported from other centers. And also a big question that nobody answered up to now, what you do with segmental deletion or gains of chromosomes. And here is another possibility. So this blastocyst, for example, is a monosomy 13 in the inner cell mass and some of the trophectoderm cells. And in some of the cells, you might have a trisomy 13. Now, if you do a biopsy and you put them all in one tube, and then you measure the end result, and the end result might be a euploidy. So you will be transferring monosomic 13 embryo as a euploid embryo. So examples like that can be drawn, many of a kind. So there was no really surprise to have this paper, and many papers followed. That was the first one in 2015, where they showed that mosaic aneuploid blastocyst transferred resulted with normal live birth. Polar body biopsy was first presented by the Verlinsky group in 1990, and many other publications followed after that. And somehow it got a little bit forgotten. In some countries, like my country in Germany, we cannot do PGS on the embryo, and even doing polar body genetic screening, it took many years. Only in 2002 it was allowed by the ethical committee to perform polar body genetic screening. It has also some advantages. It permits a fresh embryo transfer on day 3, day 4, or day 5. It is circumventing the problem of mosaicism, because there is no mosaics on the polar body. And any chromosomal imbalance in the oocytes will be present in every cell of the embryo later on. Polar body had a very difficult start. The problem was that the technique of doing the biopsy is quite difficult, and you have to be very experienced to do it properly. Also in the early days, FISH diagnosis had a high percentage of no information, and only a very few chromosomes, 5, after that 9, could be used. And these chromosomes have been mainly miscarriage chromosomes. So they were looking what was the highest percentage of chromosomes in miscarriage abortus material, and that's why these chromosomes have been used actually to detect. So these are not chromosomes that will tell you anything about implantation potential, but miscarriage potential of an embryo. And there were, of course, false expectations, because, as Norbert said before, people thought that live birth rate will be increased by selecting after polar body a normal oocyte for transfer, and that was not the case. Nowadays we have different other tools to analyze. We can use array CGH, we can use SNP arrays, we can use qPCR, and now in the late years NGS. So this helps very much in the polar body genetic screening to have more accurate results. Handyside and his group showed, by using array CGH and doing a polar body analysis, they could show and verify that the same aneuploidy or the same mistake was seen also later on in the embryo that was analyzed at the blastocyst stage. And in 2011, the group from Oxford, led by Dagan Wales, came up with this very nice paper looking at 70 patients where they do polar body analysis, first and second polar body in advanced maternal age, looking for results in advanced maternal age, repeated implantation failure, and repeated pregnancy loss. And just to summarize very shortly, they showed that recurrent implantation failure and advanced maternal age had mainly meiosis 2, more than meiosis 1 chromosome malsegregation errors. Meiosis 1 errors were more in young patient, and older patient had more meiosis 2 increased errors. And unbalanced chromatid predivision was the most frequent problem in meiosis 1, and chromosome losses have seen be more than chromosome gains, and these were the chromosomes that were mostly affected. And meiosis 1 and meiosis 2 complex abnormalities, so have many chromosomes failed, was increasing with maternal age, and the highest chromosome abnormality they could see was in the advanced maternal age, more than in recurrent implantation failure, and more than in the pregnancy loss. And they also showed that it is important to examine both polar bodies, otherwise you will lose about 50% of the information if you only check for the first polar body, as some of the clinics have done before. So in my centers, starting in 2003 up to now, we've performed around 7,500 cycles with polar body genetic testing. At the beginning, it was, of course, FISH, but since 2011, we implemented RACGH, and since last year, NGS as the main analysis of the polar body. So what we have seen here, RACGH examination of about almost 5,000 oocytes. And as you can see in the younger population, so these are patients around less than 30, and up to the age of 35, about 50% of the oocytes will be euploid, and then it goes down. So at the age of 36 to 37, only 40%, 38 to 40, around 25 to 30%, and around 40 and above, only about 50% of the oocyte will be euploid. On the bottom you will see balanced oocytes. So these are oocytes that have malsegregation in the first polar body, but they correct themselves in the second polar body. So if you look at the bottom line, this is combining both of them, you will get a euploid oocyte. So this is what we call the balanced oocyte, and that's why it's important to check the first and the second polar body, especially for the older patient, because this balanced oocyte can give normal embryos, and these are important for this group of patients. So how does it convert into the management of the patient? As you can see, in the younger patient up to the age of 35, you need a low number of fertilized oocytes to get 1 or 2 euploid embryos at the end. At the age of 36 and above, it's already difficult to get 2 euploid embryos. And in the gray bars, you will see the mean number of fertilized oocytes you can get in a certain given age. At the age of 38 to 40, it's already difficult to get 1 euploid embryo. And in the age over 40, it's difficult to get even 1 euploid embryo, concerning the mean number of oocytes that you will get at stimulation. When we looked at the number of oocytes and the age, it plateaus around 8 oocytes. So if you have 8 fertilized oocytes, you are on the safe side to have at least for each group of age to get 1 embryo at least, which is euploid for the transfer. What we also saw, and it was difficult for us to understand why, is if we transfer a euploid embryo coming from a small cohort of oocytes, it had a different implantation potential than if the euploid embryo was coming from a higher number of oocyte cohort. And it has something to do probably with the competence of the oocytes, which maybe Marc-André Serra might comment on that later on. And this was going up to 10 oocytes. So oocytes coming from a cohort that was bigger than 10 fertilized oocytes, again, we could see a drop in the implantation potential, although it was an euploid embryo. Now, during the years, and here now I only take the RACGH and the NGS results, we compared now in advanced maternal age the ongoing pregnancy rate compared to patients who did not want to have polar body genetic screening. So we offer polar body genetic screening for patients above the age of 38, and the patient can decide if they want to take advantage of that. So during the same time, you can see here the red bars are the ones that have been screened, and the blue ones have the ones who just received the embryos back without screening. So you can see that there is not much difference up to the age of 37, but there is a significant difference in the ongoing pregnancy rate at the age group above 38. So it indeed, in this age group, it helped us to select the embryo for transfer to increase the probability to have an ongoing pregnancy rate. When we look at the group 38 to 40, because most of our patients who decided, and we had the data come from this group, you can see that pregnancy rate per transfer, live birth rate per transfer, pregnancy rate per cycle, and live birth rate per cycle was all significantly increased in this group. So this group benefits indeed from transferring a euploid embryo after screening of the polar body. When we looked at the implantation rate, we could see that in every age group we had the same implantation rate. So these were patients, that the blue ones that were not tested, and the tested one are in the red bars. So you can see that even in the old patients, once they receive an euploid examined embryo for transfer, the implantation rate is the same as the young one. And I just put up here the paper from Antonio Capalbo from Rome, who looked at the same phenomenon when they did it on the blastocyst transfer and blastocyst screening. When we looked on recurrent implantation failure, and we were looking at now on the blue bars, you have the examined patient, and the red ones are the controls. So those who did not do a polar body genetic testing, you can see that in every age group, the probability of achieving an ongoing pregnancy was increased, but we could see this phenomenon only if at least 4 cycles before have failed. When we looked, and I'm apologizing for this busy slide, if you look at 2 to 3 cycles who failed before, you will not see a difference in the young and not in the older ones. But you see a difference if it's above 4 cycles. And the same is for repeated pregnancy loss. If it's only 2 to 3 losses, we could not see any benefit. But over the loss of 3, so 4 and more losses before, you can see also in the young group and also in the advanced maternal age, there is a benefit of doing the polar body screening. Now, introducing NGS helped, especially in the interpretation of a chromatid loss and a chromosome loss. So here you can see the array CGH, and here on the side, I hope you can see it, they printed the X chromosome and the Y chromosome just to help you to make a decision what is a chromosome loss and the chromatid loss. And for example, here this will be a chromosome loss and this will be a chromatid loss, and here again a chromatid gain, and here is a chromosome loss and a chromatid loss. But it's not always as clear as that. So here, for example, in the RH-CGH, this is the first polar body. Here it's difficult to say, is it now a chromosome loss or is it a chromatid loss? But if you look at the NGS, it's more clear. It is a chromatid loss. Now in the second polar body, here, for example, with the RH-CGH, looking at this, you might think this is a chromosome gain. But actually it's a chromatid gain, because in the second polar body, it's mainly a chromatid which is lost. So it might give a misinterpretation at the end of the day if you don't know exactly what you see. And just to show you, so this is a quite chaotic polar body here with a lot of losses and gains in the first and the second, but just to show you, this is, for example, polar body 1. So this is now a chromatid gain, and here's a chromatid loss, and we checked in this case the blastocellic fluid, and you see that in the blastocyst you have a euploidity situation. Now, this kind of gains and losses are more precise when we compare between the NGS and the RH-CGS. And here is just a table of different situations that we have compared between the two of them. This was a validation study to look in translocation patients. So we did first with the RH-CGH and then repeated it with the NGS, and indeed we could see that there were differences in some cases between deciding if it was a chromatid or a chromosome loss. And when we compare with the RH-CGH, we can see that with the NGS we get more or less the same results looking at the euploidity rate in the different age groups. So there is not much difference. What's helpful with the NGS compared to the RH-CGH, we have less situations that where we have no results because of amplification problems. And here you can see again, I'm just highlighted it because it's nice. These are complex aneuploidity, and you see that complex aneuploidity is very specific to advanced maternal age. And the same happens if you look at the first and the second polar body in advanced maternal age, and it is more accentuated in the NGS. You will have a complex aneuploidity and chaotic situation. We also use it for translocation, female translocation. We can use the polar body. We don't need to go to the trophectoderm for that. But it is very difficult to find a euploid embryo because you will have the aneuploidity of the age plus the problem of imbalanced translocation. So in the literature and also what we see in our patients, only about 20% of the oocyte will be euploid. So you will need at least 5 fertilized oocytes to make a probability to have one euploid embryo for transfer. And you can see indeed that only in the patients that had a high number, a good number of oocytes, we could achieve pregnancy rates because we could find euploid balanced embryos for transfer, and it was much more difficult in the advanced maternal age because the low number of the oocytes. So if I may conclude, the major application of polar body genetic testing is the detection of maternally derived chromosomal aneuploidity and translocations in oocytes, and pregnancy rate and birth rates can be increased per transfer and per cycle by polar body diagnosis in advanced maternal age over the age of 38 because of the selection. In recurrent implantation failure, if it's 4 or more implantation failures or repeated pregnancy loss. Prerequisite is the analysis of both polar bodies and the sufficient number of fertilized oocytes. And when euploid embryos transfers, oocyte embryo quality or reproductive competence is normalized across the board of female age, we have the same implantation rate. In countries where polar body genetic screening or testing on the blastocyst or trophectoderm is not allowed, polar body genetic testing can offer a good alternative for this. And with that, I want to thank also the genetic department, but also my IVF lab, who has done all this work during the years, so I can present it today to you. Thank you very much.